Am I audible?
Yes, sir. You are audible, sir.
Right then, namaskar to all. I'm Dr. Somapala Jatti, and today's session is on quality of life in management of locally advanced head and neck cancer patients. As we all know that head and neck are structurally very complex but functionally very important structures of the human body, and with the multimodality of treatment coming in case of oncology, be it radiation, surgery, chemotherapy, and the increased level of disease control is taking place. And what we can say is that with these kind of treatments come late and acute effects which might affect the quality of life. So here I would like to welcome Dr. Naba Kumar Kalita ji, and he will be talking more on this subject. He has presented, published 9 scientific papers in national and international conferences and journals. He has experience of working in State Cancer Institute, Guwahati, Assam for more than 5 years. He has participated as a guest lecturer on preventive oncology at Mangalday in 2018, presented various talks, seminars, mini teachings, and micro teachings on various topics related to medical oncology, molecular diagnostics, medical genetics, immunology, metabolic diseases, molecular and clinical biochemistry, oncobiochemistry, etc. at SCI and intra-college level. He has participated in various journal clubs held on recent biochemical markers in different biochemical in different diseases, etc. at intra-college level. Uh, I would like to invite the guest speaker to uh, to enlighten us more on this topic. So please.
Yeah, thank you, Dr. Shamya, for your kind introduction. Hope I am audible to all. And first of all, I would like to give my sincere gratitude to the Association of Occupational and Environmental Health for giving me the opportunity to talk on this very important topic. So, can I share my slide with your due permission?
Yes, please, sir.
Sir, should I start from here, sir? I will share it from here.
Yeah, I'm trying. If I get some
No problem, sir. It's there.
Can you able to see my slides?
Yes.
Sorry. Can you able to see my slides?
Yes, sir. It's there, sir, in front of you.
Yeah. So I will talk briefly about the quality of life, which is a very important aspect, especially in the management of locally advanced head and neck cancer, because it is so important not only to treat the patient effectively and with the best modalities of treatment, maybe in a locally advanced head and neck cancer, maybe we can operate with if the patient is operable, then we can give the surgical option to the patient, and after that post-operative histopathological examination, if it is a locally advanced node positive, then we may have to add some adjuvant treatment in the form of radiation, also in the form of the concurrent chemotherapy, which is very beneficial along with the radiation, and some newer modality of treatment if the patient is chemotherapy not in a position to receive chemotherapy due to some uh, comorbidities, advanced age, then we can add some biological agents along with the radiation. So these are some of the modalities. Of course, in the curable state, in the metastatic state, there is much more options. But in the curable stage, while treating the patient, it is very important to maintain the quality of life, especially in advanced head and neck cancer. So what is quality of life? That we all know that it not only just define the physical well-being. So physical well-being is just one of the aspect of quality of life, but it also comprises of some other elements like emotional or some social well-being along with the physical well-being. These three elements are very much important while we describe the quality of life in a patient. And it is just a process. It can change over a period of time, and it is also subjective. And regarding the quality of head and neck cancer, it can be affected due to the toxicities that can occur due to maybe with some most advanced surgical option where we have to some sacrifice some organs, vital organs, or maybe in the later phases when there is toxicities due to radiation along with the concurrent chemotherapy. So in all the modalities, there can be some acute side effect and the delayed toxicities that can impair the quality of life in a patient with head and neck cancer. Also very much important, some of the important aspect while treating with a concurrent chemoradiation is the xerostomia. It is very much common with the patient undergoing the radiation, especially in the oral cavity because of the firing of the parotid gland. So patient often has the xerostomia. It's a very common problem, what you could say, that very disturbing for the patients while undergoing the treatment. There may be some taste disturbances, dietary restriction. There may be some decrease appetite, decrease weight gain is not so during the adjuvant treatment. There may be some dysphagia due to some stricture that is developed, and also there may be pain. So all this factor actually hampers the quality of life. And others, some of the factors like the social interaction and depression may be also important while mentioning the quality of life. And two of the modalities of assessing the quality of life, like URTC, the European Organization of Research and Treatment of Cancer, they had just formulated one questionnaire, which is the latest version, is the QLQ Quality of Life Questionnaire C30 version 3.0, which we'll be discussing in a short moment. And also, in especially with the head and neck cancers, URTC Quality of Life Questionnaire Head and Neck 35 version 1.0. So these two tools are very much important and regularly assessed, and while we take the quality of life parameters in all the patients undergoing these treatments. So what is the URTC QLQ? So this is nothing but the European organization. They have just founded in 1962, and just they have created a quality of life group. They have seen that not only the treatment is important, but the maintaining the quality of life is also important in the cancer patients, and taking that into account, they have created a quality of life group, which is established as early as 1980. And this has actually ultimately led to the development of some questionnaire. They have formulated some questionnaire based on which they just assess the quality of life in the patients. So regarding there is some modifications. So earlier version, it was developed in 1987. It just consisted of 36 item questionnaire. It was designed to be cancer specific, multidimensional, and it is very much applicable to all the patients. So after that, some newer versions are coming up one by one. So the latest one is the URTC QLQ C30 version, where there comprises 30 main questionnaire and it just comprises of some three basic functional scales, like the functional scale, the symptom scale, and the global health status. So these three are the main pillars, and under which some of the uh, scales are mentioned, and according to the patient's performance status, they just mentioned the range, and the scoring has been done accordingly. So higher is the score, more worse is the symptom. So according to that, they just assess the quality of life in the patient. Regarding the head and neck questionnaire 35 version 1.0, it is meant only for use among the head and neck cancer patients. So it generally it comprises of a module. It comprises 35 basic questions about the symptom and the side effect that may happen in a patient with a head and neck cancer. So according to that, it consisted of 7 multi-item scales and 11 single item scales. So total, they consisted of 35 questionnaire, and according to that, they just mentioned the score. So as I have already mentioned, higher is the score, worse is the symptoms. This is just an Indian paper, so they just assesses the quality of life in radically treated head and neck cancer patient. It was a cross-sectional study done by the HMRI hospital in Patna, and the objective of this study was to assess the diverse domain of quality of life of a radically treatment head and neck cancer patient, and to discover the impact of treatment after completion and subsequent follow-up. Not only during the treatment, also they have assessed the quality of life in subsequent follow-up, how the patient fares over a period of time, irrespective of the type of treatment that is given. So they have uh, categorized. Coming to the patient portfolio, majority of the patients were suffering from oral cavity cancer. So majority of the patients were see oral cavity, and it comprises of 83.6% of the patients, and locally advanced stage 3 and stage 4 mainly comprises 76%, which is very common across all the states in India. So most of the patients coming with locally advanced head and neck cancer, which is a real concern for all of us, despite all the guidelines and all and about the tobacco uses and all these prohibitory measures taken by the government and from the NGOs and all this and from the medical organizations. But it is very painful to see that patients are coming in a very late stage, especially in a head and neck cancer, where most of the cancers are really preventable. Regarding the impact of uh, regarding the assessment of the quality of life in some of the aspects of uh, cancer treatment. So in 4 column, they have divided. The column 1 consisted of concurrent chemoradiation. Column 2 consisted of only patient undergoing only radiation. Column 3 consisted of patient undergoes surgery followed by adjuvant chemoradiation, and column 4 consisted of surgery followed by only radiation. So these are some multimodalities of treatment that can happen to a patient. So depending upon the situation, these are some multimodalities of treatment. So all the treatment they have included, and all the patients undergoing all this treatment they have included, and they had seen some of the quality of life parameters. So according to them, the nausea, vomiting, pain, social functioning, and global health status, it is relatively lower in a patient undergoing only chemoradiation, rather than, if you can see, the highest is with surgery followed by radiation. So the morbidity will be much more higher if the patient undergoes surgery followed by adjuvant RT, and if the patient is only undergoes chemoradiation, not the surgery, then obviously the quality of life will be much more better. So you can see for the score, but the p value, we can see that there is no any much difference to see at the end of the day. So there may be some numerical advantages, but there is no any statistical benefit of those patients undergoing only chemoradiation. So there may be some numerical advantage, but at the end of the day, so it is not found to be statistically significant. That means that irrespective of all the modalities of treatment, the quality of life is not found to be very bad in some of the treatment modalities. So it is found to be equally same, though the number may be varies across different modalities of treatment, but it is not found to be statistically significant. Only the nutritional supplements, and which is the only parameter they have found to be statistically significant. According to age-wise comparison, also they have they have seen that the patient in the category of 21 to 40 years, generally the young patient, they tend to do much better than the patient aged more than 60 years. You can see from the data that the quality of life is little bit good in some of the aspects in young head and neck cancer, but in older patients also they have fared very well, and there is no any absolute statistical advantage. Regarding the age-wise comparison of the pain, swallowing, and dry mouths, it is comparatively lower. The scoring is lower, tend to be lower on in 21 to 40 years group, but there is no any statistical difference to say that aged patient in aged patient the quality of life deteriorates. So by conclusion, they have concluded that head and neck cancer has a significant impact in the quality of life. We all know, and the assessment of the quality of life should receive adequate attention. So it is a very neglected actually. So head and neck while treating the patient, the quality of life is also important. And how we assess the quality of life, it is not only the physical well-being. So just we have already mentioned it is much more than that. It is the functional or the social aspect that those aspects are also to be included while assessing the patient. So it is very important to assess the quality of life in a patient with locally advanced head and neck cancer undergoing such the curative treatment in the hospital. And they have found in their papers that the nutritional supplements are the only parameters that is found to be significant in all head and neck cancer patients and should be taken care prior, during, and after the treatment. So nutritionally, the patients are malnourished in head and neck cancer because the issue with the feeding and the proper feeding is not there. So there is no any guidance. So we have to do much more rather than only treating the patient. We have to give the nutritional advices, how the patient has to take, how much is the kilocalorie they have to target, what is the amount they have to take, what is the frequency. So all these things are very much important while recovering from the surgical morbidity also, and also while undergoing the chemoradiation. So these all the things has to be taken care in a hospital where the patient is undergoing uh, the uh, the treatment for locally advanced head and neck cancer. Second study is from Hemani Agarwal et al. So they have assessed the quality of life analysis in patient treated with cetuximab. So cetuximab is a biological agent, which is also used in patients where patient is not eligible for cisplatin. So cisplatin is the main chemotherapeutic agent used concurrently with radiation, but in some patients, like in advanced age or renal problem, CKD patients, so with lower ejection fraction heart. So there is some points or patients with sensorineural hearing loss where we cannot use the cisplatin. So in place of cisplatin, so we have some targeted agents, so biological like cetuximab, which can also be used in place of cisplatin. So they have just analyzed the patients undergoing cetuximab versus chemotherapy in local regionally advanced squamous cell carcinoma of the head and neck cancer in United States. And the objective was to compare the quality of life of the patients treated with cetuximab with or without radiation therapy versus cisplatin with or without radiotherapy. So, and the eligibility criteria was locally advanced, as we have already mentioned, that stage 3 and stage 4A or stage 4B. Locally advanced patient who have received cetuximab with or without RT versus cisplatin with or without RT was considered in the study, and 531 patients with loco-regionally advanced squamous cell carcinoma of the head and neck was included, and out of that, 187 patients received actually the cetuximab, while 344 patients received cisplatin. And they have assessed the quality of life with one tool which is called the patient care monitor. So version 2, it's a validated instrument which is used to assess the oncology related symptoms. So we actually uses 11 points, Likert scale, and the scoring is given as from 0 to 10. 0 is not a problem, 10 as bad as possible. And it's an instrument that assesses 86 individual symptoms and generates 6 index score that describes the global function. So it is used in United States or in some other countries. We are not using in India. So but nonetheless, it's a very, very useful tool to monitor the quality of life in a patient with head and neck cancer. So they have assessed the patient treated with a cetuximab or cisplatin by general physical function. So there is some improvement that is obvious with cisplatin, but the scores appears to be more stable in the cetuximab plus RD cohort group. So there is not much to differentiate. Treatment side effect, there is no any there no any difference to see. And acute distress, it is more the red line is with the patients with the cetuximab, and the dotted line is patients with treated with concurrent chemotherapy cisplatin. So you can see that the acute distress, so at the beginning of the treatment, there is the acute distress is much higher with the cetuximab, because we know that it is associated with skin reaction, very much common. So initially the patient had some problem with skin reaction or some GI toxicity. So because of that, the initial acute distress was much more higher with cetuximab than with cisplatin. But with as the patient get used to, so after first initial 1 or 2 cycle, patient get used to it, and at the end of the treatment, we can see that there is hardly anything to differentiate between them. Regarding the despair, the quality assessment tool is initially because of the side effect profile is higher with the cetuximab. So the mean despair index score, though it tends to be higher in the initially, but as we go, as you have already mentioned, so as we have completed the treatment, you can see that there is hardly any difference. Both the curves are crossing each other, so there is absolutely no anything to separate. Regarding the impaired ambulation, there is nothing to separate between them, and the impaired performance, absolutely nothing to separate. So there is no any hampering of the performance or the ambulations in both the category of patients. So result that from their study that we have already mentioned, that the acute distress index, despair index, and the RAS scores are higher with the cetuximab arm than the cisplatin arm. But apart from that, the other functional score, there is uh, no anything that is disturbing for the cetuximab arm, and both the arm have fared equally regarding the quality of life. So they have concluded that this study shows some differences in the quality of life impact in patients receiving cetuximab and cisplatin with or without RT, but also highlighted the pattern of improvement of quality of life over a period of time across the treatment. So as we go, as the patient get used to it, so at the end of the day, so the quality of life generally improves. Regarding the nemotuzumab phase 3 quality of life data that was presented from the Tata Memorial Hospital by respected Nandini Madam and her colleagues. So it was a phase 3 randomized study. Patients with locally advanced stage 3 or stage 4 head and neck cancer was included with a good ECOG performance status and adequate organ functions. And the exclusion criteria was the nasopharynx, patients with nasopharynx, nasopharyngeal carcinoma, salivary gland carcinoma, and the nasal cavity, carcinoma of the nasal cavity. Those patients were excluded. And those patients were earlier received radiation or immunotherapy were excluded from the study. And it was 1:1 randomization. Arm A received cisplatin with nemotuzumab. Nemotuzumab is also an anti-EGFR biological agent. 200 mg fixed dose along with the cisplatin 30 mg per meter square with radiation 70 gray. And in arm B, they have received only chemotherapy, that is cisplatin 30 mg per meter square and radiation. And the cycles were weekly cycle for 7 cycles were allowed. And regarding the efficacy, that we have already seen that the 2-year progression-free survival with the patient treated with concurrent nemotuzumab and chemotherapy with RT. So 2-year progression-free survival was 61.8% versus 50.1% with the concurrent chemo radiation. So there is some advantage by adding the nemotuzumab with concurrent chemotherapy. The progression-free survival, it is very much higher with a good p-value, and the local regional control was also subsequently seen to be higher, and the 5 and 2-year overall survival was also seen to be uh, higher with in the form of 63.8% versus 57.5%. And the disease-free survival was also subsequently found to be higher with a good p-value. Regarding the HPV negative data that they have just regarding the subgroup analysis of those patients with HPV negative uh, data. So it is found to be much more, the benefit of adding nemotuzumab is much more higher. So it was found that the 2-year progression-free survival was 57.2 versus 31.5%. So that means that there is an incremental advantage or incremental percentage of 25.7% in the in respect to the progression-free survival. Local regional control was there is 19% improvement, and 2-year overall survival there is 18.6% improvement in the nemotuzumab arm compared to the chemotherapy, with a good hazard ratio and a p-value. So nemotuzumab, so it is generally very effective in local regionally advanced head and neck cancer, but in HPV negative, it is found to be even more beneficial, where we know that the prognosis is not so good with concurrent chemotherapy. The relapse rate or the recurrence is much more higher with HPV negativity. And in India, the HPV negativity is found to be, the percentage is found to be higher. So in Indian patients where the HPV negativity is much more common, and patient tends to recur and relapses, especially in head and neck cancer. So uses or the proper use of nemotuzumab concurrently along with the chemotherapy while undergoing radiation can give us a very good overall survival, progression-free survival, and also local regional control. Regarding that, we have already mentioned. So this is so not only it can give us a progression-free survival, but it can also give us good local regional control, and overall survival is also found to be higher. Baseline characteristics also found to be similar in two groups. There is nothing much to separate in between them, and the quality of life they have assessed by the URTC QLQC30. So that is commonly used in our parts of the India. Also, we have generally used this tool to assess the quality of life, and URTC QLQ head and neck 35% 1.0, which is also very useful in assessing the patient with head and neck cancer. That tool was also included. And in QLQ 30, both the global health status, functional scale, and symptom scale were assessed. All these parameters they have assessed in both the groups, nemotuzumab with concurrent chemoradiation versus only chemoradiation. And we have seen that there is not any significant detrimental effect of adding the second drug with the radiation. That is, adding the nemotuzumab with the chemotherapy will not going to deteriorate the quality of life. We can see from the figures that there may be some numerical advantage with the cisplatin, but at the end of the day, the p-value was not found to be statistically significant. That means that in the global health status also there is not much to differentiate. We can see from the curve that it was found to be the nemotuzumab arm. It was found to be initially it was low, but it also improved over a period of time and steadies after 3 months. So, but initially in the initial 3 months, it was low because of the patient was undergoing treatment. So So generally the global health status was on the lower side, but as the patient gets followed up, so after the end of 3 months, there is no any difference to see. Regarding the physical function, social function, also role function, cognitive function, and emotional function, all these aspects were also analyzed, and they have seen that the nadir was at the end of 3 months. So after the 3 months where the treatment gets over, the patient starts improving, and there is nothing much to separate. The patient get followed up even after 24 months or even after 36 months. Also, there is no any hardly deterioration in the quality of life. Regarding the some of the symptom scale like difficulty in swallowing, cough, pain, and dry mouth, there is nothing much to separate. And regarding the QLQ head and neck questionnaire, so they have assessed by all these parameters, and they have seen that the quality of life scores increased during the treatment, peaked at 3 months, and then declined sharply. That was the trend they have seen of in all the patients. And weight can also progressively increase after 3 months, and with the highest score at the 18 month and 12, and at the end of 12 month in nemotuzumab chemoradiation. So those patients with nemotuzumab chemoradiation, so they have improved significantly at the end of 12 months. And dry mouth also, it also increased the, uh, the, the symptom gets uh, the symptoms improved after 6 months, and there is it tends to be plateau after 18 months. So all this with all this, so we have seen from the data that the head and neck cancer is one of the important and one of the most common cancer that is found in all the cancer hospitals. Especially locally advanced head and neck cancer is it's a very much, the treatment is very much problematic, not only because it takes multimodality of treatment, the surgery, apart from the surgery, the chemoradiation is also needed. And not only the treatment, the quality of life and assessing the quality of life is also important while treating the patients with head and neck cancer. And we have seen from the data that adding the nimotuzumab or the cetuximab, it gives us a very good advantage in the form of local regional control or a progression to survival and overall survival, especially with the nemotuzumab data is very much encouraging, especially in Indian scenario. And we have seen from their quality of live questionnaire data presentation and the paper publication they have published, they have just assessed and they have analyzed that there is no any impairment in the quality of life by adding the nemotuzumab. So especially, so we can certainly add wherever it is feasible. So the biological agents along with the chemotherapeutic arm in treatment of head and neck cancer. So with that, I would like to end my talk, and thank you to all for your patient listening. Thank you.
Thank you very much, Dr. Naba. And any questions from the audience? I can see Dr. Damodar Lily has raised a hand. So please, you can unmute yourself and ask the question.
Hello, can you hear me?
Yes, sir.
Yes, sir.
Two questions. Hello.
Yes, sir.
There
Yes.
are two questions. One is, how does it matter after you do surgery and you give treatment? Because you are just finding out what are the problems. How does it help you for future treatment? That is the first question. And second question is, now when you have collected so much of data, do you take any measures to change modality of treatment or the extent of operation or whatever?
Yes, sir. So regarding the first question, that I have understood that the points that we have considered. Am I right, sir?
No, no, what you are talking about is you are finding out something that has already happened and what are the problems with the patient. But
Yes.
how does it help you for future?
Yes, sir. So especially, well, all these things are much more important, not only for the patient, but also us to know that what are the symptoms that the patient can have actually. So while undergoing the treatment in head and neck cancer. So earlier in the days, so while the radical surgery was very much evident, so with the uh, we have seen that the patients with locally advanced head and neck cancer, so the extensive treatment, extensive surgery, the patient undergoes extensive surgery. After that, the morbidity, the patient quality of life deteriorates very rapidly actually. So not only we have to see the treatment aspect, but also we have to see at the end of the day how the patient is functioning. Am I going to give any benefit to the patient? Just removing the disease is not enough. So we have to make the patient functional also. So not only the anatomy is important, but the physiology is also important. So keeping in mind of that, the surgery, the extent of surgery is also very limited. The patients are now coming with the new adjuvant therapy because we have seen that the earlier in locally advanced head and neck cancer, so the patients, the surgeon generally tends to uh, go for surgery upfront. But in nowadays, so in locally advanced, generally they want to go for some new adjuvant treatment so as to reduce the tumor burden and to see the tumor biology, how the patient is behaving with the treatment, and also with that the extent of surgery gets I can say that now the minimum surgery is possible also. So we have seen that the laser treatment. So lot of things are coming up. So I am not from the surgery background, so I cannot elaborate on this thing. But we have seen that taking the cue from all the symptom that has happened to patients. So now we have advocated for, in especially with the locally advanced head and neck cancer, we have advocated for some new adjuvant treatment so that in the form of maybe, especially in the form of the chemotherapy, so that the tumor mass decreases, the extent of the surgery get decreases, also the patient quality of life gets improved. And also we have seen that with the cisplatin is very much beneficial with the patient. So we have seen that the concurrent chemotherapy, it is irreplaceable. So cisplatin is a very important arm in treatment, especially with head and neck cancer. But some of the patients, so we have seen that due to some morbidities and all these things, so they have some age issue or some other medical comorbidities due to which they generally is not suitable for cisplatin. So in that category of patient, generally the recurrence rate is much higher because the radio sensitivity that the chemotherapy can give by adding the concurrent chemotherapy with the radiation, it is not there with the patient. So we have seen that in that category of patient that we have mentioned, that we can use some biological agent apart from the chemotherapy. So these are some of the points that we want to highlight, that the extent of the surgery. Nowadays, the people do not go for upfront surgery, so new adjuvant treatment is always preferable. And the functional skill, so minimum surgery, people are nowadays looking for the minimum surgery with the maximum benefit.
Uh, Anyone, any of the participants have any more questions? Uh, I think there are no more questions, doctor. And your talk was very elaborate, especially when you talked of emotional and social well-being. You talked about emotional and social well-being also. Am I audible? No.
Yes, sir. Yes, sir. You are audible.
So
Yeah.
you
Okay.
talked about emotional and social well-being. The score that you taught us about EORTC, QLQ, C30. That scoring, we learned a lot about that scoring system because the symptom scales were very elaborate. What we could see was that the symptom scales were very elaborate, and you talked about the numerical advantage in the studies as far as chemoradiation is concerned. You talked a lot about nutritional supplements and the difference. You showed a comparative study as far as cetuximab and cisplatin are concerned. The role of age definitely was there in the study. And now I'd like to hand over the mic to Dr. Shiniket Mishra ji, and I would ask him, request him to close this session, please.
Thank you, Dr. Jati. Good evening, everyone. Good evening, all the participants, and especially Dr. Naba Kumar. I welcome you on behalf of Haryana branch. So due to some one or variable reason, I joined late. I couldn't join on time. So a very good talk, whatever I heard so far. So once again, I thank you, and I thank Dr. Damodar Lele, Dr. Munish Rappa, and all the Dr. Rajat, Dr. Jati for moderating this session. So if there are no questions, so we can close this session. Thank you. Good night. And I would like to thank our secretariat also, Shivang and his team, for organizing this session.
Thank you very much, sir. Thank you very much.
Thank you all.
Namaste.